The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
Hello, everybody, and welcome back to the FlightBridgeED MDCast. I'm your host. My name is Mike Lauria. I'm an EMS, EM, and critical care physician at the University of New Mexico and the Associate Medical Director of our flight program. Our series continues. This one's a topic near and dear to my heart, which is refractory hypotension. How do you manage specifically septic patients with really bad vasoplegia? They're just not responding to like a little bit of fluid and a little bit of pressor. And I think this is a common problem that we run into and is something that flight crews can absolutely make a difference. And today I am joined by Dr. Brittney Bernardoni. This is a pretty unique opportunity, and I've tried to find some really awesome physicians, medics, and nurses to work with us. It is rare to find a physician that is both emergency medicine trained, does fly actively, and also works in the ICU. And Brittney is one of those amazing physicians. She did medical school at the University of Wisconsin, did residency at the Intergalactic University of Cincinnati, and also stayed there for fellowship in critical care, and now is back at the University of Wisconsin. She's the assistant medical director and one of the flight physicians at UW MedFlight, and also works in the ICU there. Correct me if I'm wrong, Brittney, but I believe primarily in the CT-ICU, correct?
You got it. Yeah, what an introduction. Thanks.
Yeah, no worries. I'm very excited because this is, I think that a lot of the time we have guests and medical directors and people from the ICU that certainly add value to the podcast, but you and a handful of others are in a unique position where you really understand what it's like to be applying critical care at the bedside at some small rural hospital as a member of a flight team. And that's pretty unique, at least in the United States. So.
Yeah, when you're out there doing the work, it definitely gives you a different perspective.
A very different perspective. So let's just hop right into it. So hypotension, I think, is a really common problem, especially in the setting of sepsis. And we've all run into these patients at these small outside hospitals, and they're really doing their best. They're really trying hard, and they've given them some fluid. They started them on some pressor, and they're calling us asking for help. So like, this person is wicked sick. We started with giving them pressor. Their blood pressure can't get their blood pressure up. They're not looking so good. And we get called, and you're at the bedside there. And I always like to think of, there's a couple of really interesting descriptions, artful descriptions sometimes, of a shock state. The gross unhinging of the mechanisms of life is, I think, one of my favorites. I think what it really comes down to is this life-threatening, inadequate blood flow, or specifically delivery of oxygen or uptake and utilization of oxygen by those tissues. And generally, I feel like when we talk about it, the connotation is we're talking about the number, the blood pressure, which is probably the best surrogate marker, I think, at least in the transport environment that's readily available to us. But Brittney, so what should we actually be looking at? Because especially whether we're using a non-invasive cuff or we're looking at an art line, it spits out three numbers. We're looking at systolic, diastolic, MAP. What do you think is the best number, if we had to pick one, and why, to take a look at?
Yeah, that's always the question I get, right? What number? What means hypotension? And the one I always stress to all of my crews and when I'm teaching is going to be the MAP, the mean arterial pressure. The reason being, this is the pressure that's actually perfusing your organs. This is the pressure your organs actually care about. Your cerebral perfusion pressure is just your MAP minus your intracerebral pressure. Your kidneys and all of your belly organs are perfused by your MAP minus your CVP. It's really the one we care about. No one cares what your systolic blood pressure is. That's the pressure that's hitting the arteries, causing the bleeding, but it doesn't actually perfuse anything. So MAP, and specifically MAP greater than 65, is the number I go with.
Yeah, I think there's a lot of debate sometimes, both in the ED and especially in the ICU. And we have the luxury of being able to monitor someone and sometimes liberalize their blood pressure or push their blood pressure a little bit higher, and we can make those decisions. But I agree. I think starting with like a standard like 65, when you don't really know the patient and you're just initiating resuscitation at the bedside, I think that's a very reasonable goal. And I think we should always, I think it's really helpful sometimes, especially in chaotic situations, to eliminate some of the academic debate and like be like, okay, this is a reasonable goal. I'm going to stick with this number. That's what we're gonna shoot for. So let's say, for example, we're shooting for that MAP of 65. We have a 63-year-old female with a history of COPD that is now essentially intubated for severe community-acquired pneumonia and septic shock. The outside hospital has given her about 2.5 liters, like 2.6 headed toward 3 liters of fluid, and has already started some norepinephrine at about 0.5, 0.6 mics per kilo per minute. And now they're titrating it up to like 0.15, 0.2 mics per kilo per minute. So let's just start out with, I think everybody and most of the crews that are listening to the podcast are very familiar with and understand pretty much everybody's guidelines now indicate that and suggest that norepinephrine is probably the pressor of choice to start out with. But what's some of the evidence behind that? Why do we start with norepinephrine?
Norepinephrine, it's going to be your workhorse. It's kind of a very well-balanced drug. It gives you a little bit of veno and arterial squeeze, which is going to both give you a little bit of blood return back to your heart. So it kind of gives you an automatic fluid bolus as it squeezes up on those veins. On the arterial side, it's going to increase your MAP. It's going to increase that perfusion pressure that we're going for. In addition to that, it also gives your heart a little bit of extra squeeze, a little bit of inotropy. It's just a super well-balanced agent that nicely hits everything we want to hit to get our patient's blood pressure up. And because it's such a nicely well-balanced agent, it's been really well studied in tons of disease pathologies and is evidence and guideline-based as the go-to. It's going to be your number one for surviving sepsis, for vasodilatory shock. It's your number one for vasoplegia due to cardiogenic shock or post-cardiac surgery. It's really going to be your workhorse for most pathologies here.
And I think one of the things that I think is always really interesting, and I hear this all the time from crews, I hear it in the ICU, the nurses will come to me like, Mike, they're maxed out on norepinephrine. And I go to the bedside and they're at like 0.3 mics per kilo per minute, which is institutionally where we have some of our soft stops. But I was wondering your take on this, Brittany. You know, is there a max dose of this drug? And in practice, both in the ICU and in the retrieval world and critical care transport, what do you consider the maximum that you go to?
So this is a really great question. And back in the day, before there were rules about subjects protection, they did some like absolutely insane trials where they just like jacked the norepinephrine up to crazy high doses in normal humans and saw what happened. The moral of the story is there really is no maximum dose. When you get to doses greater than 2.0, not 0.2, but 2.0 mics per kilo per minute, you don't get a lot of extra bang for your buck by increasing your blood pressure because you're kind of just fighting each other with your cardiac squeeze and then your increased vasoconstriction. But anything less than 2.0 is fair game for what it's worth.
I think in clinically, what I'll kind of do is say there's no like hard number that I think of, but I will start to see like a ceiling effect where going up and up on the norepinephrine isn't really getting us much bang for our buck. I think my clinical practice kind of matches what some of those animal and lab investigations kind of show, is that once you start to hit like 0.5-ish mics per kilo per minute, you really start to see that curve kind of level off. It's no longer like this linear increase in mean arterial pressure. And I feel like that's kind of where I'll start to say, maybe we should be doing something else or looking at other stuff. What's your approach there?
Exactly. Yeah, you're really not going to see as much advantage of going above 0.5. To be honest with you, I'm usually adding some adjuncts and adding some other stuff before I get that high. I like to have a little bit more room and more things to play with before I've kind of reach the ceiling of what the drug I've got running is able to do.
Cool. And I think that's a fantastic segue because what I kind of have been teaching people and I find works pretty well for us in clinical practice, both in the ICU with the residents and then in the retrieval environment in transport is I kind of think about this as my first stop point. Once I hit about like 0.25 to 0.3 and we're still not quite there yet. We haven't completely run out, like you said. We're not hitting that ceiling. I consider that like my first hemodynamic resus stop point for like a septic patient. Be like, we're really not quite there yet. We're still like have maps in the high 50s and we're at like 0.2, 0.25 and rising on the norepinephrine. What am I missing? Is there something else? Now, it may just be that we need some more pressor. There's still vasoplegic and we need to hit a different receptor or we need some more pressor. But there are other things that I tell people to consider. And I think this is where I hit like the level 2 hemodynamic resuscitation of this patient. And I consider, I would like to start really with saying like, do they really need more fluid? Some patients need less than like the random 2 per kilo or 20 to 30 cc's per kilo. Some patients need more. I've been encouraging our crews, and especially crews with advanced practice providers and physicians, to actually take a look at the patient at this point. Throw like the ultrasound probe on their heart, look at their LV, look at their RV, look at their lungs, look at their IVC, and try to generate a picture of, does this patient need a little more fluid? In fact, once or twice I've actually like had like the outside hospital staff and just do like a passive leg raise while we're like doing other stuff. And there's like this audience of people like watching us be like, hey, can you do me a favor? Can you just like hold their legs up at 45 degrees and see what happens? Because I think we should probably have some metric of whether or not they need a little bit more fluid. Once we kind of suss that out, if they need more fluid, the next question I ask is, all right, do we just need to hit a different receptor? Do we just need to add a second pressor? Now, I think the guidelines are pretty clear on this. Is your practice sort of in line with what the guidelines would say?
In general, so I think especially for septic shock, that's kind of where we have the most guideline based for any flavor of vasodilatory shock. And they recommend adding your second line, which is going to be vasopressin. So adding that at a norepi dose of somewhere between 0.25 and 0.5. Typically, that's where I'm reaching for it. However, the actual studies that the surviving sepsis guidelines are based on, the VAST trial, actually found benefit of vasopressin in patients on as low as 15 mics a minute of norepi. So for my Wisconsin patient population, that's about 0.15 probably mics of epi. So honestly, anything above 0.15, especially in someone who's just not looking great, poor trajectory, lower maps than I'm comfortable with, I'm probably going to pull the trigger earlier to get that vaso on board closer to 0.15 just to give me some wiggle room in transport. Because we all know what happens the minute you get in the elevator, the minute you get in the air.
Yeah, I agreed. Exactly. It's like anytime as soon as the key for someone to either desat or drop their blood pressure is the move from like the sending facility cot to your air cot or the striker, or once the helicopter doors close. Like once you slide the door shut, that's usually it. So what are some like the physiological, because I really try to kind of make it clear to people that it's not just an agent that gives you squeeze. There are probably some other benefits to norepinephrine that are underappreciated, which make it a good adjunct. What are some of those benefits you think, and how does it augment alpha receptor activation by norepinephrine?
So meaning adding vaso to norepinephrine?
Exactly, yeah.
Yeah, so vaso is pretty dang unique. The couple things I really like about it, unlike the catecholamines, so epinephrine and norepinephrine, vaso does not care what your pH is. Vaso will bind to its receptor and work just as well at a pH of like 6.8 as it will at a normal pH. Whereas once your pH gets less than like 7.2, definitely less than 7.1, norepi and epi aren't going to bind as well and aren't going to work as well. So it's super helpful in patients who have a significant acidosis. The other thing that's really great about vasopressin is it actually causes pulmonary vasodilation. No other agent does this. So if you have a patient who's got a sick right heart and your right heart is struggling to pump blood through all those pulmonary vessels, if you can dilate out those vessels and get a little better forward flow, that can be really helpful. So anyone with like a PE, pulmonary hypertension, bad ARDS, anyone with a struggling RV, I'm going to be reaching for vasopressin sooner in those folks.
And I think traditionally, most flight crews and ICUs are used to a standard non-titratable dose of just like the 0.04. And I think between VAST and the VANISH trial and some other evolving evidence, we've realized that's not necessarily the case. Where do you start with this medication? Do you titrate it? How far up will you go?
Oh man, that's a can of worms, especially from someone who works in a cardiothoracic ICU. I think a standard starting dose, especially for transport, is starting it at that 0.04. And just leaving it for most patients is super reasonable. That's kind of where the evidence is. That's where you leave it. Patients who I think about titrating it up in, again, would be those patients where I'm really worried about the right heart and I want to try and get their blood pressure up without clamping down their pulmonary vessels. So a lot of like post-cardiac surgery folks, patients with different RV pathology. Also the patients who are just on rocket fuel, right? I'm on like 3 or 4 other pressors, all at max doses. I've kind of run out of things. Or again, those patients who are super acidotic and just are laughing at my catecholamines. That's when I consider titrating it up. I don't love going higher than like 0.06, 0.08, especially once you give above 0.08. You get a lot more ischemic side effects of it. So ischemic digits, ischemic gut, which is less than ideal.
Gotcha. I think that pretty much matches what I do. I usually start at like, if we're really like escalating up, and part of it I think is also like the trajectory, like if you walk in and their map is like 38 or 40, and you're just like giving them push dose pressor and going up on the norepinephrine, I'll start at like a 0.04 and go up to like 0.06. I feel like rarely I go up to 0.08. So this might be a little bit of a loaded question, but especially for crews out there that have this ability and they have advanced practice providers and doctors, or it might be within their guideline, do you ever use push dose vasopressin?
Oh, it's a great drug if you are experienced with it and you know how to use it. Again, in those acidotic patients, it will save your bacon and buy you time to get a drip or something else up, mixed, and available. I think the biggest thing is just being clinically comfortable using it and accepting the fact that, hey, there's definitely some side effects of pretty significant ischemia if you're hitting them with a whole bunch of vaso really fast. But it's a nice tool to have in your pocket.
Agreed. It's definitely a tool for the toolkit. But again, unless it's in your guidelines or protocols, we're not telling you to run out there and start drawing up vasopressin in a syringe and push dose pressing it, or push dosing it. But it is a nice option and works very well, especially in patients that are like super acidotic and you're really trying to work quickly to get back on the power curve. Okay. So let's talk about, they're on like 0.25, 0.3 of norepinephrine. We've added the vasopressin starting in at 0.04 and their map's still low. And we're pretty sure they're fluid replete at this point. How do you make the decision to consider adding an inotrope? Do you usually add it empirically? Do you routinely throw the probe on their chest and look at their heart? How do you manage this?
Definitely. So inotropes are always tricky because they titrate very differently than we titrate vasopressors, and what you're titrating them to is also different. Before I'm going to start an inotrope, I generally always look at the heart, to be honest with you, because if the heart is already banging away and squeezing well, adding an inotrope, especially one that has vasodilatory properties, is potentially just going to hurt me. It's going to bring their peripheral vasodilation back up. It's going to fight what I'm already doing. And if I don't really need the extra squeeze, it's just not worth it. So I'm very rarely starting an inotrope without throwing a probe on and seeing what's going on.
Exactly. I think that's really reasonable. And I think in an era where we're really elevating critical care transport, more and more programs have ultrasound and POCUS capability. I think that's getting to the point where in the near future, not only will it be a standard of care in the ICU and the ED, but in the retrieval environment as well. Even if your program does not have or carry ultrasound, more and more critical access hospitals and outside EDs will have one. It's not a bad idea, I think, for crews, even if you don't have, your program does not have an ultrasound machine, to become facile with some of the machines out there, or at the very least, ask the sending ED provider or ask the sending team, hey, do you have an ultrasound? Can you help me? Can we take a look at the heart? Tell me what you think about these images if you're unsure about them, and really consider it. Because I think Brittany made a great point, which is if you have a heart that is just clacking away at 130 some odd beats per minute and completely emptying on every single beat, increasing inotrope probably isn't going to be super, super helpful at that point. And I think it's also worthwhile mentioning that this was something I really underappreciated until fellowship, was that a not insignificant number of people develop septic cardiomyopathy. 10, 15, 20-ish%, depending upon the literature that you're looking at. So I think it's reasonable if you have no other option and you're really stuck and you have, every single ultrasound probe has broken and you have no way of imaging the heart, adding it as an empiric third line. And I think the guidelines would agree with that. Adding it, looking at the heart first is probably the most important thing. Now, you mentioned something really interesting, Brittany, which is that the titration is different. How do you apply and titrate, let's just start out with epinephrine, for example, differently than you would norepinephrine?
Yeah, so honestly, if I'm going to be adding an empiric inotrope because my ultrasound's broken and I don't have access to anything, epi's going to be my go-to. Epi has your increased squeeze, but it also causes that peripheral vasoconstriction. So unlike something like dobutamine, which is going to peripherally vasodilate with increased squeeze, you won't be fighting yourself as much with epi if you're wrong. The difference is when we use epi as a vasopressor, we're just titrating it to the MAP. We're titrating it to try and get my MAP greater than 65. When we're using it as an inotrope, we're titrating it to cardiac squeeze. And the actual inotropic dose of epi is definitely on the lower side. Somewhere between 0.05 and 0.2 is when it functions to help increase your cardiac squeeze. When you get much above 0.2, because you're increasing your vasoconstriction so much, your heart squeeze is not able to overcome that. So you don't get any increase in forward flow. So with that being said, kind of backing up 3 steps, what do I titrate to? If I have an echo and I'm not doing this empirically, I titrate to what I see on my echo. I look at my cardiac squeeze. I pick kind of a mid-range inotropic dose of epinephrine, somewhere usually around 0.05, to be honest with you, unless their heart looks real bad or they're real sick, then maybe I'll start at 0.1 and I park it there. I'm not titrating this to MAP. I'm not running it up and down every 2 to 3 minutes. I'm starting it at my 0.05 or my 0.1 and I'm leaving it there as my inotropic dose. And then maybe in, 15, 20 minutes with epinephrine, I'm taking another look at the heart. Hey, is my squeeze better? Do things look like they're getting better? Great. We're just going to park it here. Or, hey, maybe I need a little bit more. Let's take it up to kind of the next step. So definitely not titrating it to the MAP, which is always really tricky and different from what we do kind of using it normally.
Interestingly, the guidelines do have in there, I think the 2023 update did at least mention dobutamine as an inotrope. I find myself in the setting of sepsis and like vasoplegic shock very rarely reaching for this one. Do you ever, or do you commonly use dobutamine as your inotrope? And what determines if that's going to be your inotrope of choice?
I totally agree with you, right? Because dobutamine, unlike epi, does have that increased cardiac squeeze, that increased inotropy, but it peripherally vasodilates. And that's already my problem. I've already got too much of that. So dobutamine is not always going to be my go-to. When you start it at higher doses, like starting it at 5 mics per kilo per minute or higher, you see less of that peripheral vasodilation, but it's still there. So generally in vasoplegic shock, epi is my go-to. The 1 or 2 times I would think about using dobutamine is someone where I'm worried about their right heart. Epinephrine causes pretty significant pulmonary vasoconstriction. So again, it's just increasing that pressure the right heart has to pump against. So you're sort of fighting yourself, whereas dobutamine does not do that. So that would be kind of the one instance with a vasoplegic shock plus a little RV sadness, where I'd reach for that one as opposed to epi.
A sad RV is not a good thing to have in sepsis and vasodilatory shock. That's for sure. Mm-mm. So we've talked about the pressors. We've talked about inotropes. We talked about fluid. There are some other things that may actually be helpful and influence things. And certainly, are in the setting of systemic inflammation and septic shock, we know that there's other things going on that can affect the HPA axis and or our alpha and beta receptors' ability to do their job. And so I think it's important to consider some other things here. So let's start with a topic near and dear to my heart in the ICU, which is steroids. How are steroids useful? And is there like any science or evidence to like support that steroids can be helpful?
Oh yeah, the magic hydrocortisone, right? So it actually is pretty dang evidence-based. We have studied this left, right, front, center, up and down, and it does seem to truly help patients, especially patients with sepsis. So the current surviving sepsis guidelines recommend that when you're on norepi more than 0.25, you consider stress dose steroids. The dose used in most of the trials was 50 milligrams Q6 hours. Some providers prefer to start with a loading dose of 100, but honestly, dealer's choice. It's a nice adjunct. It does help, but you're not going to see this acutely. This isn't going to be like an epi push. You're not going to see a magic increase in blood pressure during your transport. You're probably going to see the effects like 6-8 hours down the road in the ICU, but definitely something worth doing that's super evidence-based that'll help your patient later on.
Yeah, agree 100%. So I'm usually in the somewhat unevidence-based 100 milligram loading dose camp, and then transitioning to 50 Q6. And I think it's nice because this is something that crews can do. You can have in your guidelines. It's certainly within the scope of providers and nurses and paramedics to provide. And I don't think I've run into an outside ED, even in very small critical access hospitals on the Navajo reservation here, that don't have hydrocortisone. And so I think it's really easy to get a hold of, even if it's something that your program won't stock or doesn't want to carry. Fine, like you can get it from the sending facility most of the time. I think there is some debate about, some people have said, well, there's no mortality benefit to steroids. Well, I think that's number one, somewhat controversial, because there at least have been a couple of studies that have shown that. I think there are studies, there's a couple of very interesting studies. In particular, I think it was Approaches, where they added the fludrocortisone, which did show a mortality benefit. Either way, I think some of the studies that very clearly show that it at least limits the time that someone's in shock, I think you can consider that an important patient-centered outcome. Like, shock, generally not good. Being out of shock, generally better. And I think it's absolutely something that crews can get going before they leave, especially if you're doing some of these longer transports. Get it going right away, as opposed to waiting 2 or 3 hours by the time you get to the receiving facility. So awesome. We're adding some hydrocortisone, starting with 50 or 100. Now, I think what we see very commonly is also patients in septic shock, where their lactate is 8, 10, their pH is 7.05, 7.1, somewhere around there. And we are going up and up on the norepinephrine. We're adding things, and we're just not getting a lot of ground. So why is it that, pH affects blood pressure?
Yeah, so that is the age-old question, right? Does the pH matter? What pH is too low? The biggest thing is, like we mentioned before, when your pH gets low, your catecholamine, so your epi and your norepi, they just can't hit those receptors well. They can't bind well, and you're not going to see the same effect as you would at a normal pH. The pH where we generally start to think of our pressors not working is usually somewhere below 7.15, 7.1. A little wiggle room in the evidence there.
It's hard to say there's really robust evidence here, but there is some pretty cool in vitro and animal data that suggests this is true. And although there's no randomized control trials, I would say, like, across the board for retrievalists, ICU providers, people in the emergency department, this is a very real physiologic phenomenon that we see on a daily basis. We have a couple options, and two mainly, right? We can help from a respiratory standpoint, and we can help from a metabolic standpoint. What's your approach to helping to at least get the pH up above 7.15, Brittany?
Absolutely. So honestly, if they're on the ventilator, which most of the time they're all on the ventilator at this point, step one is, can I optimize anything there? What is their PCO2? How low can I drive that down? So looking at a blood gas, if you've got point of care labs or just have the sending hospital send a set of labs for you, see what their PCO2 is. Trying to bring that down as much as possible while maintaining lung protective settings. I don't love dropping my PCO2 much below like 25 to 30. When you start getting lower in that, you worry a little bit about cerebral vasoconstriction and kind of brain perfusion, which is poor form. But that's kind of my go-to first step.
And I think that's something that's quick and easy, and often we have pretty good control over, especially if they're ventilating. The slightly more controversial approach here, but I think there's a good reason to do it, is replacing or providing them a magical medication that I think is helpful in a lot of instances. And what might that be, Brittany, you think?
Oh, the bicarb controversy. I think the biggest thing with bicarb, and before you consider giving it, you got to play with that vent first. The reason being, when you give someone bicarb, it basically breaks down into CO2. And unless you're able to blow that CO2 off, you're able to get rid of it and therefore decrease their pH. Giving them bicarb is actually going to leave more CO2 in their blood and could actually make their pH worse. And honestly, I think this is where some of the controversy around bicarb comes from. If you're not compensating for giving a push of bicarb or a bicarb drip by taking your minute ventilation up, you're not going to see a change in your pH, and you may actually see it get worse. So before I even consider getting it, I want a patient where I know they're able to tolerate me taking their minute ventilation up without hurting their lungs.
I think the common pitfalls we see is people who are, for example, they're going to be intubated and they're hypoventilating. We don't have much ways of like increasing their minute ventilation, and people are pushing peri-intubation pushes of bicarb when we can't off-gas that CO2. And I think there's, on top of what you said, I think there's also some reasonable in vitro evidence, and at least raises the question of, could it be actually making things worse? Can it actually cause paradoxical intracellular acidosis that's worsening when you can't blow off that CO2? So I think that's actually a critical point. So I'm really glad you brought that up. What's your approach to replacing it? Just like Q 10-minute amp of bicarb, you put them on a drip. How do you manage it?
So step one, assuming I'm confident that I can blow off this extra CO2 I'm going to be giving the patient, is how do I give it? When do I give it? So kind of the when question, that's the first thing I think about and I teach my crews. There is actually a pretty nice trial that in patients with an AKI, so kidneys that are dumb and are peeing out their bicarb because they can't hold on to it, you want to go ahead and think about replacing bicarb when the pH is less than 7.2. That was the bicarb ICU trial. So if they have a pH less than 7.2 plus an AKI, good time to be starting the bicarb. Otherwise, even though the classic teaching is you don't give bicarb to a lactic acidosis, as we've hammered home in this podcast, if their pH is low enough, I'm not going to be able to get their blood pressure up. And if I can't get their blood pressure up, I can't fix their lactic acidosis. So there's some evidence that considering starting bicarb when your pH is less than 7.5, even in a setting of a lactic acidosis, that's going to allow your pressors to work and allow you to actually get that perfusion. That's when I start it. So how do I start it is always the next question. Whether I give a 1 amp bolus or not depends how confident I am that I can blow off that CO2. When you give it as a bolus, you've got to have a much quicker increase in your minute ventilation to blow that CO2 off. So if I'm happy with their lungs, I think I can blow it off. I go ahead and give that 1 amp bolus. And then usually I'm starting a continuous bicarb infusion. It gives you a much more smooth effect. It's just like push dose epi versus an epi drip, right? Like I can sit here and push it, but then I got to remember to give it. They spike and they come down. It's way smoother just to have a continuous infusion. And when starting a bicarb infusion, this is something that honestly my crews catch all the time, is it being mixed incorrectly, especially by the sending hospital. So when you have bicarb, how we standardly teach to mix it is 3 amps of bicarb, which is 150 milliequivalents, in a liter of D5 or sterile water. This basically gives you normal saline with 150 equivalents of bicarb. Because remember, bicarb is sodium bicarb. If you're going to put 3 amps of bicarb in a liter of normal saline, you've basically created 3% normal saline with bicarb, which is poor form to give to your patients. And let me tell you, we find patients all the time on a 3% normal saline drip with some bicarb in it. So once you get those 150 milliequivalents, those 3 amps in a liter of D5 or sterile water, we generally start that at 150. It's just easy to remember the numbers. 150 in a liter, run it at 150. That gives you about a half an amp, so about 22.5 milliequivalents an hour, which is a nice, smooth starting dose to help bring that pH up.
I think one of the interesting things, especially working pre-hospitally in the ED and in the ICU, is our ICU colleagues will routinely pull that card and be like, well, if it's a straight up lactic acidosis from sepsis, then there's really no mortality benefit. It doesn't help. It's not useful. Well, I think in reality, we've all seen a couple things. One, it's often mixed anion gap and non-anion gap metabolic acidosis. Two, they almost routinely have some degree of AKI, right? They almost have some degree of acute kidney injury, and they're poor little riñones, as we call them down here in New Mexico. They're not reabsorbing bicarb like they should be. And three, I always encourage people, remember that in the transport environment, especially, our goal is to really stabilize this person and get them to a tertiary or quaternary care center we can really look at more labs, tweak them carefully. We have more options. We have more resources. So for a number of reasons, I think this is even more so than in the ED and ICU, a very reasonable option. And my approach is the same. I think the bicarb ICU trial was actually done with like 4.2% bicarb. I don't have the bandwidth or like the mental aptitude to really to figure out the mix in like 500 cc's or a liter. So I just do exactly what you did. Also, D5, even if you don't carry it on your aircraft or in your bag, again, most EDs will have it. So just getting that asking for a liter and 3 amps, asking for a liter of D5 and 3 amps is pretty easy. And then I pretty much start similarly. I do like an amp or two slow push, like over a couple minutes, and then start them at like 150 to 200, which I think is a really reasonable starting point for them. Let's talk about another electrolyte, this time a cation that is near and dear to our hearts. Let's talk about calcium. When do you think that we should be adding on calcium, giving them calcium chloride or calcium gluconate? How much? These are all, I think, very controversial issues. But what's your approach clinically?
Oh man, yeah, especially with some of the new evidence coming out with kind of calcium and calcium repletion, especially with arrest. What's solidly evidence-based is if their calcium is low, you should probably make it normal-ish. And that's about the closest we can get to solid evidence. What I will tell you is calcium's a really nice vasopressor. It causes peripheral vasoconstriction, especially when you fast push it, right? I think we've all seen kind of pushing that calcium chloride and watching them get a little bit hypertensive. So I kind of love it as my ninja push dose pressor to give someone amp of calcium chloride while getting something else mixed and up and ready, because it's just there and it's easy to kind of quick push. Now, as far as the evidence, there's no mortality benefit. There's some studies that say kind of pushing the calcium up or aggressively repleting the calcium might cause some harm, but there's not great evidence that'll cause some harm. So for me, it's another tool in my toolkit, and especially that calcium chloride push is kind of my ninja push dose pressor when I'm getting other stuff up and running. Gluconate is nice. You can run that in a little more slowly. The thing to remember is to do dosing equivalency. It's 3 grams of gluconate to 1 gram of chloride. So I really, really frequently see people underdosing gluconate for what it's worth.
I think it's really interesting looking at the evidence because anecdotally, like we've all seen that transient, like awesome bump in their blood pressure. We're like, this stuff is magical. But at the same time, we know that it's often transient and there's no strong evidence that it helps save lives. And that bimodal mortality distribution where it really sucks and you're more likely to die if your calcium's super low. You're more likely to die if your calcium's super high. And hitting that nice point in the middle is really important. That said, I agree with you. If they're hypotensive and as a sort of finger in the dike maneuver, empirically giving them half an amp of calcium chloride is not unreasonable. Just across the board, giving it to everybody who might be sepsis or shows up in the ICU with a borderline or kind of low calcium is probably a bad idea. But I think we have to remember in this particular scenario, in this refractory shock case that we're talking about, I think the risk of having a map of, a 58 and, mottled skin and acute kidney injury and all these other issues, the risk of not addressing that is probably higher than the potential risk of driving their ionized calcium to like 1.2 or 1.25. So I agree with you. That's sort of my MO and feelings as well. So let's say we have thrown all of that stuff at them. We have repleted their bed. We have them on a bicarb. We're doing all that stuff. And we're still barely eking out a map of like 58, 59, 60. Now we go to like the level 3, somewhat, at least at this point, kind of Hail Mary, not super strong evidence-based, but may again at least be like finger in a dike until we can get them somewhere and better for better diagnostics, assessment, and management. What are some of those therapies? I call these like the level 3 therapies, the like everything else is kind of failing therapies.
There's a lot of them. The problem is the ones that probably have the best evidence and they're most well studied are the ones that are probably the hardest to get a hold of if you're, rural, middle of nowhere, pre-hospital, which is real frustrating. So some of the ones I think about is sort of my man, we are on triple pressors. We've gotten an inotrope on board. We've done all the calcium, all the bicarb, all of the steroids. I mean, we're still circling the drain. What next? Those are going to be things like angiotensin 2, methylene blue, and then cyanokit. That's the one you actually might be able to get a hold of, which is nice to know.
I think the angiotensin II stuff is very appealing and very interesting. And I'm super excited to see more of the research that's being done. We're actually enrolled in the dark sepsis trial. So we're watching some of our patients in the medical ICU with acute kidney injuries on escalating pressors, starting them and seeing what happens. Again, just investigating it. Methylene blue seems like it's magical sometimes, especially I think more on the CTICU post-cardiotomy vasoplegia shock. It seems like it just miraculous things. Sepsis, I feel like we've just been, a lot of times we wait so long. And I think some of the evidence that favors it early on, which is more in like the retrieval setting, right, might be helpful. But I mean, I can't imagine any of the emergency departments that we go to that might have it. But the cyanokit might be an interesting option. Can you talk a little bit about some of the evidence behind that and the dosing and why it's probably reasonable for retrieval crews, CCT crews?
Yeah, definitely. This is one of my favorite things to educate about for critical care transport, because this is one of those things we can reach for that like we can probably actually get a hold of. I think if anyone who's given cyanokit in the setting of worrying about carbon monoxide poisoning, it can cause hypertension, right? That's on the box. That's one of the side effects of cyanokit. So honestly, we're just taking advantage of this hypertensive effect. It actually works really similarly to methylene blue. It basically causes peripheral vaso and venoconstriction by scavenging up all the nitric oxide that's floating around, which we know there's more of that in the setting of sepsis and vasodilatory shock. It's not as well evidence-based as angiotensin II or methylene blue, but there's definitely evidence for it. Most of that evidence is like post-cardiac surgery, post-liver transplant, but there's also some evidence using this in sepsis. So it's not going crazy off the reservation to give this to your septic patient. Most places recommend giving the exact same dose as you would give for carbon monoxide poisoning. So just mix it up and give it just like you would for anything else. So just that 5-gram bolus. It'll last for at least a few hours. It's great just to buy you some time to get you through this kind of like long transport. It's super important though, when you drop the patient off, to let them know you gave this. Similarly to methylene blue, it turns your blood all kinds of funky colors and it messes with any lab that uses colorimetrics. So when they start peeing bright orange, it's nice to know why.
And I think you can point out, logistically, it's awesome. It's the same 5-gram dose. It's literally like one bottle, like one cyanokit. So that's why I think it's just such an easy and an awesome option. And at this point, again, do we routinely give it to anybody who's hypotensive? No. But when you're really, really struggling to get their MAP to perfuse all of their organs, I think it's totally reasonable. I think that was an awesome review in terms of escalation of therapies. So remember, guys, when you have someone who's at an outside hospital and they're septic and they're in septic shock, think about those initial therapies. Make sure they're appropriately fluid resuscitated, and norepinephrine is definitely our go-to as a first line. Remember that there's not necessarily a max dose, or at least the max dose is much higher than we think, but there's probably going to be a ceiling dose around 0.5-ish mics per kilo per minute. When you hit those level 2 therapies, definitely, if you can, revisit, make sure they're appropriately fluid resuscitated. If you have to reach for a second pressor, vasopressin is definitely an awesome option and recommended by the guidelines. Think about if they need some inotropy. A lot of patients have septic cardiomyopathy. If you can, really, really try and take a look at their heart and consider adding probably epinephrine, and in some cases, like Brittany talked about, okay, and probably reasonable to consider dobutamine, but usually epi. Think about their pH. You can compensate with it for the vent. Adding some bicarb is not a bad idea. Repleting calcium to normal, giving them an amp or so, is also very reasonable. And stress dose steroids, consider giving them a dose of hydrocortisone and continuing that. And of course, if you're really, really maxed out, you've done everything else really well, considering the cyanokit or some of those other therapies. Quick note, as always, if some of this stuff is not within your guidelines, make sure you're talking to the sending physician or the receiving physician and have approval to do some of these things, or at least it's in like verbal or written orders for you guys. Brittany and I are kind of discussing some of the evidence. We're discussing the science in our practice, but never does what we talk about supersede local laws, policies, protocols, or guidelines. So just make sure you're always following those first. Otherwise, thank you guys so much for paying attention. And this was on hypotension, refractory shock and sepsis. Brittany, thank you so much. Take care. Have a good one. Be well.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.